Okay, are we ready to start streaming? Yeah, ready to go. Okay, so thank you very much, everybody, and a warm welcome to this afternoon's public part of the Greater Manchester Joint Commissioning Board meeting. Just for members, can we remember to use our mics as we're being live streamed and we need to be heard clearly. And also, please try to avoid the use of abbreviation, jargon. Let's try and make it easily understandable to all of us and to all members of the public who are here in the public gallery or maybe viewing online. In terms of welcomes, a warm welcome to Andrea Green, new Accountable Officer for Stockport CCG. Great to have you on board. And also, if we could perhaps just note, Joint Commissioning Board, our thanks to Noreen Dowd for her contributions during her time as the interim at Stockport CCG, and we wish her all the best for the future. Okay, Lindsay, you've got some apologies. You're going to note those for the minutes. In terms of Chair's announcements, I don't have any, but Rob, you do have a couple of pieces of urgent business.
Oh, thank you, Tom. Really just a couple of process points for today's meeting. So the first thing to say is that all 10 localities are represented in the room. Andrew Lightfoot is here as Deputy Chief Executive of the Combined Authority, representing Eamon Boylan as Chief Executive, who's away, and obviously the Health and Social Care Partnership are represented through John Rouse and indeed Sarah Price. So we are fully present and quorate, just for the record. And also relating to our terms of reference, item 5, which is the item on improving specialist care, is what's regarded in the terms of reference as level B business, which for those who aren't aware of that means that members are bound by the outcome of any resolution that we make in that regard. Thanks, Tom.
Okay, thank you, Rob. Declarations of interest, a form was circulated with the papers, so please do complete that and return it to Lindsay as appropriate. And if you do have a conflict during the course of the meeting, please raise it with me and we'll decide how to action that. Okay, so moving us on through the formalities, the minutes of the meeting dated 16th of July, are we happy to accept those as a true record?
Agreed,
yes,
Chair.
Thank you. Rob, you're going to pick up some key actions, matters arising.
Yeah. Thank you, Chair. So the three that I've got in terms of the matter of the Vice Chair, we have now a nomination for Clinical Vice Chair of this board, which would be Dr. Wirrin Batiani, who is the Clinical Chair of Bolton CCG. So we'd ask members to formally receive and approve that nomination from the Clinical Chair fraternity.
So looking around my colleagues, everyone's nodding. We were aware of that, so we're happy to support. Thank you.
Yeah. And secondly, just a brief update. There's reference in the previous minutes to extending the terms of reference of this board to be able to make it capable of taking local authority decisions as well as NHS decisions. I'm working with Liz Tracy, who is the solicitor for the Combined Authority on this, along with Sarah Price on some specific programmes of work. So we have now devised a parallel process which would see the specific service proposals coming through in parallel to the appropriate local authority governance. Meeting with Liz, the governance process, which involves wider leadership team, chief legal officers, this board, overview and scrutiny, and then ultimately cabinet, would take a period of about 2 months. So therefore, from the time when we've got a firm proposal around the business to be transacted, there's a sort of 2-month governance process that goes along with that. And I think, Sarah, I'm right in saying that we think sexual health is likely to be the first area where we'd want people to consider how we might choose to use such a delegation in the future. So to let colleagues know that that work is ongoing in the way that we described in the previous minutes. And finally, there was a matter arising about the population health update, which Sarah provided last time, and there's a reference in the minutes to that coming back to a future Joint Commissioning Board executive, and we have that provisionally scheduled for the October executive, Sarah. So I think from my perspective, Tom, the specific actions that we took last time are all in hand in the way described.
Okay, that's great, Rob. Thanks for the update. So moving us on to our first substantive agenda item, which is around improving specialist care. We were asked to make some key decisions today. There's a series of recommendations that we will work our way through. But I'm going to invite Anthony Hassel, our lead for improving specialist care, to open in terms of presentation of the paper. Thank you.
Thanks, Chair. We have provided in your pack a detailed paper which I hope provides, together with the appendices, a strong and detailed and broad overview of where we are at in relation to the programme and the recommendations which we would like you to take forward today. However, what's really important to say about this programme, which is called Improving Specialist Care for a Strong Reason, is that this programme is about work on a number of specialties where there is strong and broad clinical agreement that we have a depth of resilience challenge across Greater Manchester that requires us as commissioners to take action. We have and are used to, I think, a journey of changes to hospital services over a number of years, which, whilst in some cases have been difficult, have delivered positive and improved outcomes for patients. And this programme is a continuation of that journey, covering a number of broadly surgical, but there are some other specialties which are currently delivered in an unsustainable way across Greater Manchester. And the genesis of this work, it has been and continues to be dialogue and discussion between and with clinicians who are telling us that the configuration of services in these particular areas are suboptimal and are meaning that we could do better for both in terms of outcomes and in terms of the services that patients deliver across Greater Manchester. So you as a JCB have previously received updates on the case for change across each of these specialties, and let me just remind you what they are, around respiratory care, around vascular surgery, around benign urology, around paediatric surgery, and around breast care. You have previously received and been updated on the reasons why we need to act in respect of these services. And they are broadly because they are all suffering from shortages of key and specialist workforce. They are suffering from high and continued levels of demand and shortfalls in capacity, and therefore real questions about whether we can continue to sustain the current configuration of these services across Greater Manchester. And let me be really crystal clear that predominantly these services are about care around surgery. This is not, particularly in the case of breast, about proposing any changes to the current configuration of breast screening services. This is about the service around particularly surgical care, in some cases prior to surgery and after surgery. So we've developed models of care in each of these different areas. They have been developed by clinicians, with clinicians. Each of these models of care has been presented to the JCB for their review. And indeed, as part of the process, we have brought together clinicians from outside of Greater Manchester to test the models to ensure that we are not developing these in isolation and are taking account of best practice developed in other parts of the country and in some cases internationally. We have also included throughout this process, although we are not yet at the point of any formal consultation, very significant engagement with patients and patient reference groups such as Healthwatch, who have been involved in our process all the way through. They have been able to receive information and ask questions about the development of the models of care and what is proposed within the models of care. And of course, that is good practice that we will continue as we further develop the programme. The point of decision today is, if you like, a staging post. We are asking you to approve the development of something called in NHS England language a pre-consultation business case, which enables us to develop a further level of detail and a further level of information around the proposals that we're developing in each of the specialist areas. It also allows us to formally begin engagement with NHS England and with the Greater Manchester Health and Care Scrutiny Committee. We've already engaged with both NHS England and the Greater Manchester Scrutiny Committee in an informal sense up to now. This decision point, though, allows us to begin that engagement with them formally prior to making any final decision on a preferred strategic configuration of these services, which the JCB will make at a point in time in the future. So what I did just want to do is to summarise the options that we are asking you to make decisions on today. So in terms of vascular surgery, what we're proposing is one option which gives us a single tertiary hub at the Manchester Royal Infirmary, but with spokes across the rest of the conurbation, including those sites which would deliver perhaps more complex surgery and those delivering less complex outpatient type care in vascular surgery. In respiratory care, we're actually not proposing any changes to the locations of the current model of respiratory care, but we are proposing to level up standards of care in a number of high volume respiratory areas such as chronic obstructive pulmonary disease, the treatment of flu, etc. And we will hopefully through that process remove current variation in care. Around paediatric surgery, again we are proposing one option, which is the retention of the Royal Manchester Children's Hospital as a tertiary centre, 3 centres delivering a higher level of paediatric surgery, and then a number of centres which will deliver lower levels of paediatric surgery spread across the conurbation. On benign urology, again we are proposing one option which locates 5 hub sites coterminous with those under the Healthier Together proposals, and a number of spokes, again, spread across the Greater Manchester conurbation. And in all of these proposals, these are underpinned by keeping, as far as we possibly can, outpatients and diagnostics delivered locally, and only where any type of surgical intervention is needed, centralising those on the hub sites. In breast, though, what we're asking you to do today is to approve the taking forward of all 4 options to pre-consultation business case to ensure that we have the opportunity to delve into a higher level of detail around the criteria that we will use to assess the delivery of a preferred option, and they will be criteria such as the optimum workforce configuration, a key analysis of travel times, estates, impact on outside of Greater Manchester, and impact on the remaining services within those hospitals. Detailed in the paper is the analysis that we have undertaken to date, and we will use that analysis to take forward further consideration of a preferred option. So, Chair, I think that's where I will pause at this point. We have presented within the paper a huge amount of detailed information that we have undertaken since over the past few months in terms of analysis of criteria, particularly around the breast option. But the a recommendation that we want to ask the Joint Commissioning Board to agree to is, as articulated on the slide, and taking each specialty in turn, but then also to give us permission to move to that dialogue with both NHS England and the Joint Health Scrutiny Committee, but then really importantly and finally to prioritise work on the breast, urology and vascular models of care, and particularly around breast, because we know we have current challenges around the current fragility of breast services across Greater Manchester. And to give the Joint Commissioning Board some assurance, in tandem and in partnership with the Provider Federation Board and with the Greater Manchester Health and Care Partnership, we are undertaking a immediate piece of work to support the 5 current providers of breast surgery services to ensure that we are able to support resilience on the current model of breast surgery, as we know that that is very fragile and suboptimal currently. And so that piece of work is currently and urgently underway around breast surgery. I'll pause there, Chair, and perhaps ask for some general comments and queries before we go into specific, perhaps specialty level discussions.
Okay, thank you, Anthony, for your introduction, which is very succinct and clear. So, if first of all, can I open it up to any questions, because this is a key, important agenda item for us. Martin, sorry. I was trying to look around the room and I couldn't see you there. Okay.
Oh, sorry. If it's in the paper and I've missed it, I apologise for this. Given the potential codependency between the outcome of the orthopaedics process and the pre-consultation business case options on breast, are we confident that those two pieces of work will come together in the same timescale to allow us to make that choice at that time?
Yeah, so thank you. And what you will note in the papers is that, as agreed through the governance arrangements that the JCB approved, the ISC programme board was at its meeting in August able to, in respect of breast services, point to a recommendation to take options 3 and 4 forward for pre-consultation business case consideration. But as is also noted in the paper, throughout this process we have been in receipt of legal advice, and following the consideration of the evidence at the ISC programme, Improving Specialist Care Programme Board in August, we reviewed where we were at with our lawyers. And the reason, to be clear, that we are doing that with lawyers is to ensure that we follow as strictly as possible the law in respect of requirements on us as statutory organisations to make any service change. And what transpired out of that discussion was that our previous decision to pause decision-making on the orthopaedic model of care because of the fact that we had asked for some changes or some reviews to be undertaken around that orthopaedic model of care, meant that there was, and the fact that some of the proposals around the breast options did reference future potential changes to orthopaedic activity. The legal advice meant that we would be wise to take all 4 breast options forward for further consideration, pending completion of our review of orthopaedic services. So we will do that in the next 2 months, I think. We're hoping to bring the orthopaedic model of care back to you in November, and that will then, I am hoping, allow us to bring consideration of the breast and orthopaedic pre-consultation business cases at the same time, so that we can be absolutely clear that we have considered, discounted or taken account of any codependencies. So that's, sorry, a very long answer to what was quite a simple question, but important that you get the flavour of the codependency.
Okay, thank you, Anthony. Keith, please.
Yes, not a question, Tom, it's more of a comment around this. But I mean, I fully support the recommendation that's here at JCB today. For me, one of the issues around Greater Manchester devolution of health and social care was the ability to have some flexibility and innovation and do things slightly differently that suit us. I'm not sure that the level we've gone to at present is anything that you wouldn't see in any STP around the country within the NA.
Sustainability and
Transformation Program. So I think this conversation will be going on in many areas around the country in a similar way that it's gone on here. So I know that there are opportunities to do things slightly differently, and I think moving on as we develop the option appraisal and the pre-consultation outline business cases, that there's an opportunity to look much wider than the pure, I mean, clearly the pure clinical and financial costings and travel. There's actually an opportunity to look much wider than that. So what I'd like to see really going forward is one, because we're looking at these in specialities, I'm not sure what the combined implication is for each locality and each hospital when you combine all the impact of what we're doing in each speciality. So something around how the viability of each hospital would be confirmed and generated. The other thing is, I think that in order to, whatever decisions we come to eventually, in order to justify that to people out there, and not just clinicians, but to the population of this metropolitan authority, is to look much wider about, I've talked before in this about community wealth building, social capital and social value. So whatever we do within the public sector should be adding some social value, should be building social capital, and should be community wealth building. So what is the impact socio-economically on the locality and the area as a result of the decisions we are making in terms of skills, in terms of employment, in terms of opportunities, and in terms of building some community wealth building within there. So for me, as we're going forward and doing the options appraisal, I'd like to see a lot more of that. I do know Anthony's had a number of responses around some of these, and some of them are quite clearly ill-informed or deliberately misinformed and are clearly unhelpful. And so I think in order to be really specific about it, showing the wider benefit, not only of improving clinical standards, improving clinical safety, but actually benefiting the communities and the localities involved would be helpful.
Okay, thank you, Keith. So I think sort of two key points then. One was around the critical mass for each of the hospitals across Greater Manchester and the further work that you've done over the summer months regarding that. And then secondly, around the economic implications, which is actually covered in our priorities paper later on. But Anthony, if I could ask you for any comment around the first question in particular.
Yeah, and thank you for that. I suppose my response would be that that thinking is absolutely at the centre of and has been at the centre of the programme. So the JCB will recall that one of the underpinning pillars of the programme has been the commitment that we have made through something called the hospital archetypes work, that nothing in what we are doing here would threaten, for want of a better word, the provision where it currently exists of a 24-hour A&E, for example, or of maternity services, or of medical paediatrics, for example. So, and the clinicians have considered this this issue on a number of occasions, but I think it's a point well made that what we don't want to do here in reviewing, and I think rightly reviewing, these specialist areas is threaten the overall viability of what we term as our local hospitals. And I think what the JCB needs to receive from me is that assurance, and I think it has been at the centre of what we are doing here, is that none of these proposals have been judged by the clinicians that have been involved in them to threaten that bedrock of hospital services where they currently exist. We have included in the paper some analysis, of what is, I think, called compound impact, and I think that again, the presentation of that at this stage indicates that, subject to the changes that we. Subject to making the changes all the way through these models of care, actually the impact on both income and activity levels across some of the hospitals will be broadly neutral, because of course as this plays out, sometimes this is an unfortunate language, but I'll use it, there will be some services moving from a site to another site, but equally there may be services moving back in to that site that has seen some services move out of it, which broadly mean the impact is neutral, because what we're trying to do here, and it's in line with those changes that I referenced right at the beginning of my narrative, is create a concept that hopefully we're all familiar with, which is centres of excellence, where clinicians can come together in larger teams to deliver improved outcomes for what are broadly once-in-a-lifetime events in the majority of cases. But I think it's a point well made about us keeping a weather eye on what might be called the compound impact of these changes on the viability of local hospitals, and I know that members of this committee will keep us in check around that. And then just finally, the point about social value. So we have considered that, and we will continue to consider it going forward. But helpful to keep us in check around that.
Okay, thank you, Anthony. So I'm just going to bring in a couple of points. So one was really from discussions I've had with clinical chairs outside of this meeting. We would fully endorse the here and now approach to some of these very fragile services, and in particular breast. So we recognise the Improving Specialist Care programme will look to develop sustainability into the future, but there is a need for us to work on the here and now, and conversations with John Rouse and colleagues, this is a system priority. So we as a board will want to be kept up to speed in terms of the developments around that and be fully involved. Kath Briggs, who's our Stockport CCG chair, and Kath has a background experience of having worked in urology for a number of years. Kath is keen to emphasise that benign urology is one part of the system, and that there's an opportunity by hopefully accepting the recommendation today for us to look at how we align benign urology with urology cancer services across Greater Manchester. So there's just a small caveat there. Of course, in terms of urology, a key component is going to be the interface with community services, with our local care organisations, and then that desire to keep care as close to the citizen's home as possible. So just a couple of quick points there. And the final one was actually from Chris Duffy, the Hayward, Middleton and Rochdale chair, who are supportive of the recommendations, but they would just like a better understanding about timeframes for the services that are going through the process. I don't know if you could just give us a brief update on that last point, please.
Yeah, so thanks, Chair. So I suppose there's two things I'd say. So I think we as a system are working right now on the resilience issues that we face, particularly around breast surgery services, because we know that there are some in-the-moment issues facing us across the 5 services across Greater Manchester. There isn't one site across Greater Manchester that can hold itself up as not suffering from some type of resilience issues. So either lack of crucial workforce, increase in demand, or some type of constraint. So there is in the moment work around that resilience issue in terms of breast surgery. On the question of the wider point, I think what we've indicated is we will prioritise the production of the options appraisal and the pre-consultation business case in breast, urology and vascular. We will prioritise the resource that we have to do those three. We're working up the exact timeline that we will work to, but I foresee that being the next 2 to 3 months that we will do that work and then hopefully bring back an update. But what we will undertake to do is to bring back an update at every JCB or JCB exec to ensure that you're in the loop on this. And of course, I know we'll be having individual locality discussions on this as we progress.
Okay, thank you, Anthony. Ruth?
If you don't mind, I just wanted to bring it to life a little bit based on the comments we've had already and sort of partly in reference to what Keith has said, because for me this is about creating the next step so we can do what we really want to do. And I think we haven't focused on respiratory a great deal because that's probably in one of the best places, but it gives us the best examples of what we might hope to achieve in terms of for our communities. So I think Anthony's point that this is a once-in-a-lifetime event that we're talking about today for most patients sits within a much broader context of how people experience healthcare. So if we took respiratory and COPD or chronic obstructive pulmonary disease, people's admission to hospital will be a small part of their disease experience. But the things that we are seeing that are absolutely brilliant and I think that we'd all hoped for were things like the community approach to caring for people with long-term respiratory conditions. So we've got choirs, we've got community groups which are also addressing loneliness and frailty. It's all of that added value that I think that makes this really different. But if we don't do this bit now, then we can't do the bits that really, really matter to patients. So I think urology is another place where there's a really good example where we can think about what a community offer needs to look like for people who are having regular prostate monitoring, for example. Does that really need to be done in a hospital setting? Can we put the wraparound care in a much better place for people where we also manage out other things such as, again, loneliness and frailty? So for me, that's where this gets exciting. This is the bit we need to do that next bit. And I just don't want us to lose that, because from a patient's perspective, this isn't the biggest bit of what matters to them. It's the biggest bit of what matters to those of us that are organising the system, and it's the biggest bit that matters to the people that are doing the operations, but it's the extra bits that being a devolved health and social care conurbation, you know, that's the bit that's going to make the genuine difference. So this puts everything in place, and then we can absolutely get those other bits right. And as I say, respiratory is probably our best example to date of why that's already happening.
Thank you, Ruth. Good points, well made. Thank you for those. Okay, any other comments? Tom?
Thank you, Chair. I think the points, Anthony, you make about the here and now and the fragility are really important. 2 or 3 weeks ago, we still had a breast service in Stockport, very fragile. It was at the point, we thought we'd got through the system and got through it to the point where it was able to work, and the unintended consequences of that on the population and people who are going to have their operations done all over the place, and on the staff. Had that been planned through the review, that might have been a very different experience for people. So, you know, the immediacy of that decision that had to be taken and everybody agreed to it had serious consequences. And I think the point you're making about the fragility, that could happen elsewhere.
Yep, thank you, Tom. Okay, any other comments before I lead us through the recommendations? Okay, so Anthony, if you go through the recommendations, then I'll chair the approval of them, please.
Okay, thanks. And we'll very specifically, I will be asking for your approval very specifically on each one of these, and it should be minuted as such. What we would like you to do is to approve the proposed configuration of respiratory services as modelled, so that will be on all existing sites and consistent with the model of care that you've already reviewed and agreed, and so that we can proceed, we can take that to the production of the pre-consultation business case.
Okay. Any questions on respiratory? No. Are we happy to approve? Yes, agreed. Thank you.
So on vascular, as indicated, this is about the approval of the hub and spoke configuration, again consistent with the model of care that you've already received, and again progress that to pre-consultation business case.
Thank you. Any questions on vascular? Happy to approve?
Agreed.
Okay.
So this next one is benign urology. So again, this is as modelled on a hub and spoke configuration, consistent with the model of care that you've already received, and again to progress to the pre-consultation business case.
Okay, so mindful of comments made by colleagues not here, which we will obviously minute. Any further comments to be made? No? Happy to approve? Agreed. Agreed.
So on paediatric surgery, again, this is as modelled, the single option with a tiered configuration, consistent with the model of care that you've already agreed, and then progress that to pre-consultation business case.
Happy to agree?
Yeah.
Okay.
Okay, so just on breast, and let's be really clear, this is breast surgery, this is not about changing breast screening services. This is about 3 equitable hub sites consistent with the model of care to progress to pre-consultation business case, but we will do that covering all of the options 1 to 4.
Okay, so this is the only recommendation where there's more than one option in terms of sites. Are we happy to approve all 4 options proceeding to the next stage? Agreed. Yes. Agreed.
And then recommendation 2 is just to allow us to then progress conversations with both NHS England, the GM Joint Health and Scrutiny Committee, and then obviously underpinned by the production of the pre-consultation business case.
Happy to approve?
Yes.
Yeah, thank you.
And then your formal agreement that we'll prioritise the production of the pre-consultation business cases in the 3 areas that are noted: breast surgery model of care, urology and vascular, on the grounds of their fragility, and bring those back to you as soon as possible.
Thank you. Happy to approve?
Agreed.
Yeah, and we definitely want to be kept cited and up to date in terms of that piece of work. Thank you. Right, thank you very much to Anthony for taking us through that. Thank you very much for everybody's contributions. A really important decision for us to get right, and we're now able to proceed to the next stage of working up the options appraisal and the pre-consultation business case. So I'm going to move us on to our next agenda item, which is around specialised commissioning, and this is the annual report from 1819. And Sarah, I think you're presenting this paper for us, please.
Thank you, Chair. So this is just to update you on the position around specialised commissioning. As you may remember, we have devolved responsibility around specialised commissioning in areas that are largely commissioned on a GM footprint, and that of the £1 billion spent in Greater Manchester, just over half of that fits within that category. So we have oversight of about £550 million worth of general acute specialised commissioning and about £45 million worth of mental health commissioning responsibility. So in terms of the benefits of that, we have been looking very closely at how we join together some of the pathways that potentially are separated because they're commissioned separately, to bring those together to think about how we can make sure that we've got a more seamless approach and one that takes a more upstream position so that we make the very best use of the resources that we've got. So our ambition is really to fully commission those pathways together, and we make coordinated decisions. The responsibility for those Tier 1 specialised services sits with John personally, but he wants to make those in the context of this group and making them alongside CCG-based decisions. So HIV commissioning is a very good example of this, where local government has a huge responsibility around sexual and reproductive health commissioning, but HIV commissioning all sits with the specialised group. So we are in a position uniquely in Greater Manchester to be able to bring that together and to think about what the future of that might look like. And we mentioned earlier on that we would be looking at how we might do that in a more effective way with our strategy, which will come back to this board later in the year. The other responsibility I mentioned is mental health transformation programmes. Nationally, there's a huge move forward to try to focus on place-based commissioning and providing coming together. We're already doing that in Greater Manchester because we've already got that opportunity. So providers and commissioners sitting together looking at some of those services around low secure care for adults or child and adolescent mental health beds, and how we might manage that more effectively, more prevention and support for people, some of the investment that we've made through the Transformation Fund that will be supporting that work. And by bringing the commissioning together, we think we're in a much stronger position. We're also looking at some new innovations, the transgender service for adults that we're hoping to commission, that Craig is chairing that work. We hope to start that fairly shortly, that pilot on behalf of NHS England nationally. That would mean a really big difference to that community within Greater Manchester. But again, us trying to use that understanding of our population, what our place needs, and being able to take that work forward. Some of the things that we've done in the last year have been able to, because we've got the sort of information that other places won't have around those services use and spend at CCG level. Other places won't necessarily have that, and by type of service and organisation, we've been able to understand some of the things like the right care data, which suggested, for example, in neurosciences that there was a large gap between our spend and what efficiently we could do. But when we were able to look at that in depth, actually the spend was largely appropriate. So although that didn't make a great big saving, £8 million, which we went into it thinking we might be able to make, we were in a position to know whether that was real or not. And I think that's a real advantage because there will be examples where we can look and actually make saving perhaps that wasn't predicted. The intention, as I say, is to try to bring those services together, to look at them in a more joined up way, to make best use of the money. The next step is a discussion that we're having about finances. So although John has the responsibility for decision making, the accountability for those services, we don't have a responsibility for the money. And that was decided originally partly because we didn't have the information to know how much was appropriate to transfer to Greater Manchester. We do have that now, but also the risk that might be involved if we were to overspend still sits with the North West specialised commissioning team. We think now we're in a position to argue for a bit of balance, so there'll be a bit of risk share, but also some benefit gain, because some of this, you'll have noticed from the financial figures in the report, that on those Tier 1 services, we actually had an underspend in the last financial year, which is great because we really knew what we were doing and we were on top of it. But on the other hand, we didn't benefit from any of that saving in Greater Manchester. And if we want to make some of the reinvestment that's going to be needed lower down the pathways in order to prevent the need for specialised services, we need to hold on to some of that cash within GM. So some of the negotiation that we're participating in at the moment is all about how we try and retain some of that money for GM so that we can reinvest. So some of the schemes that we've been running may be funded through TF or whatever. If we're going to make them sustainable, we need to be able to have access to some of that funding to be able to do it. So I think we're at the forefront of what we're doing. I think we've come a long way in the last year in both the data that we've got on what we're doing, but also in the understanding of where we're spending our money. And I think we're in a really strong position to go forward to share some of the benefits that we're creating through that shared position financially. So just to say, hope you'll find that information useful. And if you've got any questions, I'll be more than happy to answer them.
Okay, no, I think it's relatively straightforward. Thanks very much. A lot of hard work's been done, and as you say, real progress. And certainly this is an area that I think we can go further on. So look forward to continuing to work with you on this one. Papers very much for noting, which we do. Okay, so I'm going to move us on to corporate service delivery vehicle updates, which is a bit of a mouthful. So Stephen Kennedy, it's his report, but he's unfortunately not here with us today. So in his absence, Rob, you're just going to talk us through this.
Thank you. I know everybody always looks forward to this item when we get to it on the agenda. So this actually is an important moment in this process, because I think we've had several updates of the process that's got us to this point, and we've now reached a point in this where there is now a preferred provider for a preferred host for this corporate services delivery vehicle, which is Salford Royal NHS Foundation Trust, who've been through a process and have duly been selected. So the purpose of this report is to bring that to the attention of the board, having you signed off a series of points along the process, to note the timeline which is attached at the appendix, and really just to note that decision and to be cited and indeed comfortable with the next phase of the process. So I wasn't going to say much more than that, Tom, but an important milestone in quite a detailed process.
Okay, so it's really for noting this paper. Any key questions? No. So we're comfortable with the recommendations to note the preferred hosting decision and cited on the next phase of the development. Good. Okay. Thank you. So Rob, it's back to you for our joint commissioning priorities paper, which has been around for a while now. We've seen various incarnations of it, so we're hoping that this is going to be for approval today. But if you can just talk us through key points.
Thanks, Tom. And this is effectively the last substantive item. We've got some process items later on today's agenda, and this is deliberate, really, because we wanted to end the meeting today. We've zoomed in on what Anthony's described as once-in-a-lifetime type issues we've gone through, and we've zoomed in even further with specialised services today. And this is to bring us right back out into the wide angle and to start to allow us to set out our stall for the next 18 months as a joint commissioning board, really focusing on improving the lives of the 2.8 million citizens that we serve. So a very deliberate move to bring us right back out into the broader strategic agenda. So a couple of things I wanted to pick out from this paper before inviting any questions and comments. And the first of those are the themes that are set out on, I think it's page 262 in the pack. It's section 2 of the report, because I think this talks back to some of the points that were made in the earlier items and points that Keith particularly was making, because those themes are there to underpin all that we do. So we are about working not just as a joint commissioning board in this room, but working as co-production partners in a system. So we'll view the effectiveness of what we do in this room via our level of connectedness to the wider system, rather than our degree of separation from it. And so I think that's something that makes us different in Greater Manchester, that we have a room like this, but the room like this is defined by its willingness to collaborate and co-produce. Clearly quality, clearly performance are key factors of all we do, and there's work going on in those areas, linking back to the work that the Partnership Executive do, that we obviously have very strong connections back to. And those last 2 points I think are worthy of repetition and note, is that this is all about place. But when we collaborate at a conurbation level, we collaborate because there's a case to do so, and we do it very well and very strongly. So I would see the role and function and effectiveness of this joint commissioning board as being an absolute prerequisite to us being able to do what we need to do at place level as well. The two things are mutually beneficial and mutually rely upon each other. And the final point, I think, in that table talks directly to what Keith said, and it takes us back to our initial devolution vision, which was a vision based on wider public service reform. It was about population health improvement, acting as that catalyst for wider economic growth and prosperity of our city region. And forgive me for dwelling a little on those things, but I think those things are what defines us as a JCB, and are hopefully what makes us, it does make us different to other of these strategic transformation partnerships that we referred to earlier. And moving on to the priorities themselves, and I've fallen into my own trap there, because we've talked about priorities until quite recently, but we've changed that terminology because we're now talking about core focus areas of this board. And what we mean by that is are the areas where we think, which this board thinks are core to its existence, and where we can make the most difference as a board. So that means we're not going to try and double handle things that are going on perfectly adequately and perfectly well in the right parts of the system, but the things on this list are things that we feel as a JCB we've got a unique and distinctive contribution to make. And it's no accident that the first three things in those core focus areas are all about this wider vision for public service reform, transformation and sustainable development, and that's very deliberate. I won't read them all through. As Tom says, they've been hopefully well socialised, but I'm trying to bring out some context. Just to say that in the table, TBC is not the initials of a very busy person. They're items of things that are to be confirmed in terms of the leadership. Since this paper was written, Craig Harris has kindly agreed to be the lead accountable officer for the mental health work that we're doing, working alongside Tom as the clinical lead. And I think it's been agreed that in terms of the meeting our duties and commitments around public service, access, etc., I think all accountable officers felt that was a core part of their own responsibility in their own place. So that's basically all accountable officers are the lead for that, because it's part of the very nature of their roles. Moving forward through the paper, there is an update in here in section 3 on the Future of Commissioning Action Plan. People remember the Joint Commissioning Board signing off that Future of Commissioning report earlier this year, the piece of work that Will Blandamer did on your behalf. This is an update on where that is up to and where we are on each of those recommendations. Happy to take any questions on that at the end. Similarly, section 4 is there for completeness, because that's talking about some of the specific projects and programmes of work that my team, in the Joint Commissioning team, is working on, with some timelines about when they will be coming forward. And lastly, and just very quickly, Tom, I just wanted to reflect on section 5, which is principles for implementation, because those are, I think, some of the things that will define the next stages of where we go with our health and social care devolution programme. Again, some of these themes have been mentioned already on today's agenda. So we will always co-design and co-produce. We will always wish to be there at the beginning of the process to shape it, as well as shaping it throughout its life. The concept of distributed leadership, and we've seen examples of that through this afternoon in terms of the programmes that we've talked about today, but that should apply more and more, and does apply more and more, to all of the programmes that we're running. Consistent with that model, when the capacity to deliver programmes needs to be aligned to the distributed leadership model, and linked into that, it's important that we recognise the unique contribution that all of the parts of the systems can make. So what's the role of, and how do we harness the role and capacity of John and Sarah's team, the Health and Social Care Partnership, my team, the Joint Commissioning team, the partnership work we do with the Combined Authority, and so on, so that we're acting as greater than the sum of our parts to make this happen. And the final point there is that the team that I manage, the Joint Commissioning team, just to give assurance, is subject to exactly the same set of efficiency requirements and savings as any other part of the system. So I thought I'd better just acknowledge that point before somebody asked me the question. So Tom, that's an overview. Hopefully people will feel that this is something they have seen before in forums, but hopefully they will also have seen that as a result of those engagements, it's a more comprehensive and a more reflective paper than it would otherwise have been. So I'll stop there and ask. Thank you.
Okay, thank you, Rob. John?
So, first of all, well done, Rob, and to you and your team for getting us to this point. I know it's not easy to take a vast array of potential areas of work and align them in the way that you've done, and that gives us a bit of a route map. So, I just want to acknowledge that. I suppose the counterbalance to that point is, if I've got one concern at the present time in terms of taking forward the work plan, it's about pace. And when we establish sub-governance, and particularly when it's complex governance like this, the danger is that in seeking to do the right thing, we do no thing, because we end up going too slowly. And thinking very much of the fact that we've got these 3 live pieces of work at the moment around end-of-life care, respiratory and cardio, where we've got some excellent work that has been done by our independent strategic clinical networks. And while we may not have the right level of system ownership of that work, it is good work that we want to see in the system as soon as possible. So I wondered, maybe using those as examples, whether you could give us a little bit of a deeper, detailed route map in terms of how we're going to make sure that work gets operationalised into the commissioning system as soon as possible.
Thanks, John. Thanks for those remarks and for the question. So yeah, in terms of that specific point, and as you'll know, we've been doing, and I think it's a good example of the co-production model that I talked about, because there's been some work going on at the, over recent days and weeks, really, between John and his team, my team and the provider federation board, about how we do land this stuff in a better way, because it's a great shame that the work goes on, high quality work by high quality people, and then it doesn't land appropriately. So in terms of the strategic clinical networks who've led on each of the 3 pieces of work that John's just described, we are looking in very short order, and I'm talking days and weeks rather than months, to set up an interim steering group around the strategic clinical networks. And in fact, for JCB members, there is a paper that's going out. I'm going to press the button to send it tomorrow morning that gives you a more detailed briefing on that specific issue, setting out the stall for doing that. But absolutely, that will happen. And the view is that we can't wait for some of the longer term pieces of work about the way that we're going to manage improvement in months and years to come. We need to do something here and now, and that's a good example of something we'd look to address within the next few weeks.
Bev, next, please.
Thanks. And I think the point around pace is one that we can also think of when it comes to reporting on the progress of some of these measurables. So I think the thing that strikes me is we've been spending quite some time talking about our priorities for a plan that started to come in April, and for obvious reasons it's now September. So I think we need to be quite realistic in terms of what we can achieve. I think it was a reflection for me on, I mean, obviously an enormous amount of work has gone into bringing this to the point that it's at, and to try and condense what felt like 6 million different priorities. The last time we looked at them into paper is never an easy task. I think what would be helpful for me with future reports when updating on progress is maybe being mindful of the connectivity between themes, focus areas, sub-deliverables, JCT-specific pieces of work, and you can see that the point that I'm making, and actually perhaps having them a bit more thematic under one overarching thing that we're trying to achieve, rather than breaking it into the process in a sense, because it can feel a little bit disjointed, bearing in mind it's a public document as well. And I think it will then be easier for us to track the pieces of the work that are happening and actually be a little bit clearer in terms of our successes. I think then just a few sort of smaller points. I think it's good to see climate change and sustainability in there on page 263. I would argue actually that shouldn't be a specific theme of work, but that should be something that features in each of the themes of work as kind of a key driver, rather than having one person lead on sustainability and climate change across all of these pieces of work, because I feel like we're setting them an insurmountable task to essentially solve climate change in the entire health and social care system. Looking at Anthony, who's always getting a lot of what seems like very large tasks. Yeah. So I think that would be a specific. And then the final thing is one of the recommendations around the priority set in section 4 for the joint commissioning team. And I think the thing not to lose sight in this, and I think what this paper does do, is knits together the population health with the role of JCB and some of the other pieces of work. But it's probably the discussion that I would have at Partnership Executive Board and also the Health and Social Care Board is around GM having the opportunities of social care and not losing sight of that. So also, you know, if we're going to talk about continuing healthcare, actually in a lot of our localities we're looking at the opportunities of bringing together social care and healthcare packages. So actually having a specific piece of work just looking at CHC runs the risk perhaps potentially of losing the opportunities of locality and GM, rather than simply looking at what can be done at scale.
Incredibly helpful for all of those points, Bev. And I think just a couple of that I'd want to come specific. So I think your point about how do we structure reporting in the future, well made, and we'll reflect that. In terms of climate change and sustainability, I've still got the words of Tom ringing in my ears from the last time when we first talked about this, which was he wants me to and the team to come back with how is this going to feel different, and it has to be more than we feel better about ourselves leaving the room because we put it on a list of priorities. It's how are we going to behave differently as a board. So to start that process, I attended part of the steering group which Sarah chairs on Friday, and we talked about how we would, rather than trying to set up a parallel industry around the JCB, we would connect to the work that Sarah and Anthony and others are leading around the system and try and put the shoulder of the JCB to that particular wheel rather than trying to look at it in a separate way. But the challenge that Tom set, I think...
Can I make a specific suggestion on that? What we do in the local authority is asking every single piece of work that we do how this contributes to carbon reduction and environmental and climate sustainability. Maybe that's the kind of model that I was suggesting, rather than simply just... I agree a work stream may be beneficial, but we should be asking Craig, when he's leading on work around mental health strategy, what his contribution is in that strategy too.
Yeah, absolutely. So I completely agree with that. And the final point was around the CHC, and I agree with you, because I like the fact that we've got a piece of CHC work going, but I worry because it's putting, continuing healthcare for members of the public. I like the fact that we're doing that piece of work, but I worry because it puts a label against the person, and there's a risk that we forget about the people and the family rather than they're a CHC case or this or that, so we mustn't do that. I will say there was a brilliant conversation about this piece of work last Friday morning, and there were representatives of the Directors of Adult Social Services group in the room to make that point, so that's really helpful. And the final point I would make, linked into that, and Stephen was in the room when we did it, we had a brilliant conversation about this paper with the Directors of Adult Social Services about 2 weeks ago, and they, I think I'd be right to say, Stephen, I think they felt pretty aligned to the work that we're doing, and we've got to build on that and make sure that that happens.
Okay, thanks. Ruth, you wanted to come in?
I'm not sure if it's linked to what was said already or not. You can decide, Rob. But I think what I'm about to say is linked to each other. So we had a conversation at Chairs last week about dispersed leadership being an opportunity, but also recognising capacity. And I don't want any gold stars, but I worked all weekend and I'm going to work all next weekend. And I suspect a lot of us do that. So we just need to be mindful of the amount of work there is to be done in the system and how that's going to be done. For me, the opportunity is that this can bring in new leaders and perhaps people that haven't been recognised to date in our organisations to their full capacity. So I think that's, in full potential. So that's something that I think we really do need to think through. It can't just be the same group of people taking on very big projects, which then leads into the fact that I would like us to hold us accountable for actually genuinely making a difference. So I was really, really struck by your paper last time, Sarah, where we talked about obesity and food poverty. And actually, there's lots of different things going on in population health, which you couldn't single one out and say, we're going to stop doing it. But equally, if we really, really focused on one area, there's a lot of evidence to suggest that might be the area that we'd really, really get ourselves behind. So for me, this is an opportunity to do a bit more of that, to really focus in on quite specific pieces of work where if we work as a collective GM partnership, we can actually do something that makes a difference to lots and lots of people in our system, and particularly, I guess, for the people that need it the most. So that's what I was going to say.
Thanks, Ruth. Thank you very much. Okay, any other comments?
Stephen?
Oh, sorry, Stephen, you wanted to come in, yeah.
This is a very quick comment, really, to support what Bev has said around climate change, but also to make the case for the work that Anthony's, about framing Anthony's work, to make the case for Anthony's work, because at the same time as we need to call out on every single issue the climate change point, I think there is a significant job of work for us, all of us to do, to get our workforces to be carbon literate, if you know what I'm saying. And I think that is one of the critical pieces of work that we should all individually and collectively commit to.
Yeah, I mean, I think, we did think long and hard where it should be a core focus for the for the next 18 months. I think we've really got to raise the profile, so it needs to happen at different levels. But I think if we've got a champion like Anthony and then, potentially a clinical lead or even a political lead, Brenda, it doesn't have to be a clinical lead.
Thank you.
Well, Bev, you're obviously very passionate about this. There we go. Job done. Right, so let's whiz through the recommendations because I'm aware that we're sort of going over time and we need to get people away. So are we happy to approve the priority areas as set out in section 2?
Yeah.
Yes, good. We know the connectivity to the GM business plan. Are we happy to confirm the leadership arrangements? So the updated table with Craig for mental health and all accountable officers for the performance measures. Is there anybody who wants to come forward in terms of any of the vacant positions here and now? So, Brenda, you volunteered yourself for climate. Thank you. That's great. Ash, you volunteered to be deputy for the sort of integrated care aspect. So if we can note Ash as my deputy for that area. We've got urgent care. We need a clinical lead in urgent care at a GM level. Okay, so I think it needs to be a fairly senior clinical lead that takes on that role. So, perhaps if we can have a discussion outside of this room about, whether it's a chair or whether it's a senior clinical or medical director from within the commissioning system. I do think we need to give that one some thought. Are we missing any others, Rob? I've lost the page.
No, what we'll do, I'll correspond with colleagues just to confirm that outside of the meeting.
Yeah, okay, good. Note the progress in terms of the implementation and future of commissioning. Approve the JCT, the Joint Commissioning Team priorities, as in section 4, and approve the principles in section 5. Yeah? Okay, great. So we've got a couple of reports left, which are very much for noting. So, Rob, any key points you want to bring out in terms of the JCB executive?
No, just there for process.
Okay, so that's noted. And Margaret, commissioner report.
Quickly, 3 points.
3
I just
points.
wanted to, and it's in the report, and actually they connect with other reports on this agenda, so it's positive. So in terms of John, I know John's left, but in terms of end of life, that was a really, really good quality piece of work that the Strategic Clinical Network did on the end of life, audible aspirations. But what we didn't know was if by signing up to them we knew what that meant for each of our localities. So we did agree to do a joint piece of work very, very quickly with Strategic Clinical Network and Directors of Commissioning to say, what does this mean for our locality in terms of where we are, because we're all at different places, in order to be able to support that framework moving forward with our eyes wide open, really. So I just wanted to make that point, because it absolutely was a really quality piece of work, but we didn't really know what it meant for our locality. Second two things to kind of just to draw to the attention of the board was really on the review of the commissioning review. So, and it kind of one builds on Sarah's point. So Directors of Commissioning are working with Chief Finance Officers looking at how do we streamline how we commission for acute services, and part of that is around what can we do once at GM level and just do it once, and that frees us up to do work with our localities, but also how can we nip back the CCG and the NHSE pathway, so that kind of builds on what Sarah was saying earlier, so that we have actually one conversation with providers and not two conversations, and that's been the kind of history hitherto, really. So there's a piece of work going on there, and we'll bring back recommendations to JCB. I think the second one, just to draw to the attention of the board, is the work that certainly Directors of Commission have started on what does it mean to be a strategic clinical leader, a strategic commissioning leader, sorry. We started to do that piece of work ourselves, if you like, and we've broadened it out. And in terms of, we've had really honest conversations around actually we're at very different places. We've got new leaders in our system. We have different approaches, but the appetite to move towards outcome-focused, place-based commissioning is absolutely a really strong appetite. And one of the things we have done since we've met as a board is I opened it out and had a session where we brought Directors of Adult Social Services, Director of Children's Social Services and Directors of Public Health together to look at our respective programmes. And I think we recognised that was the first time we've all ever been in a room together. So we looked at our professional work plans, but also there was a signing up, if you like, to saying how do we come together to deliver that aspiration of being a strategic clinical commissioning leaders in our system. So it was really positive to say that there was that appetite, and we've got I think a first meeting coming up next month where there's going to be a place-based commissioning leader coming together. What are the 2-3 big ticket items that by coming together we can go further faster in terms of the aspirations and to support the work of the JCB.
Thank you, Margaret. That's all your hard work and your report. Any comments? No, we're asked to note. Takes us to the end of the meeting today, so thank you very much everybody for your contributions. I think largely we managed to avoid abbreviations and jargon, and we've also taken some very important decisions, so thank you for your attention.
Thank
So I'm going to write out my own.